The topic for today is going to be depression, anxiety, and apathy. We've talked a lot about depression, and depression is highly linked to anxiety. I won't spend that much time on it. We've covered that before, but I'll go over it a little bit. Apathy, I'll speak a bit more about it. It's a tricky concept, apathy, because there's overlap with depression. And then what's the most interesting component of this little session will be what we call a dopamine dysregulation syndrome. That's what the scholars call it. But it's the fact that many patients who take anti-Parkinson drugs develop compulsive gambling, hypersexuality, and obsessive compulsive kind of activities. And that whole thing of dopamine dysregulation syndrome is very problematic when it affects people. Fortunately, it doesn't affect everyone. It tends to happen more in the younger onset Parkinson's disease patients. And typically, it's not part of untreated Parkinson's disease. In fact, just the opposite. When you have Parkinson's disease untreated, very likely you won't be that interested in strange sexual activities. You won't be that interested in gambling. You won't be, have excessive obsessions or compulsions. It seems to be that Parkinson's disease treated with dopamine replacement drugs results in this dopamine dysregulation syndrome. And it's quite fascinating. I'll give you some examples of how we deal with it. So first of all, depression. We all know it's extremely common in Parkinson's disease. And it's associated with reduced quality of life. And so an individual who's depressed is going to be withdrawn. It's not going to be very interested in doing anything. And the quality of life for the patient and his family and caregivers is going to be obviously less. About 21% of patients with Parkinson's disease have an active clinical depression. It's major depression, not just feeling depressed every now and then. I mean, major depression that requires psychiatric care, or at least requires treatment with antidepressants. That number is probably higher, but if you consider a wider spectrum of depression. Generalized anxiety disorder, which is often linked with depression, maybe is in around 11 to 15% of patients. It isn't just an anxiety that many patients experience as the drug is wearing off. They get very anxious about being off, and then that anxiety disappears once the levodopa is given and they come on again. But just a generalized anxiety about everything. So that's an issue, and quite often it doesn't exist by itself, but it's associated with depression. Panic disorder. That's amazing to me that it's reported in one of the reviews that I looked at to occur in about 30% of patients. And a panic is just like an extreme anxiety, and it can be pretty serious, where people feel that impending doom. And about 19% of patients, about 1 out of every 5 patients, has the comorbid depression and anxiety. So apathy. The apathy is just think of pathos and empathy, and it really relates to ability to, it deals with a person's emotions and feelings. So if you're empathic, you can identify with a person's emotions and feelings. So a good physician should be empathic, should be able to kind of see things from the perspective of this patient's sufferings. Oftentimes, physicians who deal with a lot of suffering build a shield for their own health and don't let the empathy get too strong. So they're anti-pathic, so to speak. And what is it exactly? Well, apathy is a lack, what appears to others to be a lack of feeling, and the patient themselves feel like no desire to do anything, no feeling, just blah, empty. So the way it's defined is it's a constellation of behavioral, emotional, and motivational features that include reduced interest and reduced participation in normal activities. What used to be their normal activities, well, they're less interested in doing it and thinking about it or even acting on the things they used to do. That's the behavioral part. The lack of initiative in initiation, any kind of activity, or what's often part of apathy is unable to sustain activities. You might start because you're kind of given pressure to do a certain thing, but you just won't follow through. There seems to be a lack of concern and indifference in a person who suffers from apathy. And by the way, apathy is not just Parkinson's disease, it's a condition that's seen in many other situations. But it's extremely common in Parkinson's disease. And the thing that's always confused me is that oftentimes you can tell if a person's apathetic. They tend to be indifferent, they have no emotions on their face. But we remember that because of the motor problems in Parkinson's disease, a patient has less spontaneous movement of muscles of the face, and we read people's emotions and feelings through their expressions. Just think of it. You can just look at a person and tell if they're sad, happy. Well, the happy is the easiest, right? Big smile, laughing, etc. But since patients have a, quote, masked face, it's hard to distinguish that blank expression on the face from apathy versus just the motor manifestations of the illness. So, this thing keeps on giving me problems here. Okay, so how common is it in Parkinson's disease? Well, there are several reviews I came across, and one paper they say about 16% of the patients meet the criteria for apathy, and I'll tell you there's various rating scales that they use in questionnaires to determine if a person has apathy versus depression, because there's a lot of overlap. But in some of the papers, it's 42% of patients have apathy who have Parkinson's disease. It's almost half will have some kind of apathy. And a lot of the caregivers will tell me, yes, my husband just doesn't want to do the things he used to like to do, even though he can walk and his motor function's okay, right? Depression and apathy coexist, and depression has a very similar feature there, lack of interest in doing activities that used to bring them pleasure. So depression and apathy is like a hand in a glove. You know, they're very similar. They go together quite often. And there's another thing that's associated with apathy, is a cognitive decline. I think so depression and cognitive decline is a component of apathy in a sense. And what does this cognitive decline? Well, there's many aspects of cognitive decline that we call dementia, and there's a mild cognitive impairment that eventually becomes dementia. And I had a session on that in Parkinson's disease, how the cognitive decline in Parkinson's disease is different than that of Alzheimer's disease, which is different than that of dementia with Lewy bodies, different than that of vascular dementia. But the dementia of Parkinson's disease, the cognitive decline, often involves inability to initiate actions, to perform executive functions, which are initiation of actions, multitasking, following through on tasks. And it's really hard for them to be able to do a responsible job because they can't follow through. And that's, without apathy, that's just an executive function deficit. But when you look at the criteria for apathy, it involves some dysexecutive function. And why is that? It's the frontal lobes, the last part of our brain to develop. And our frontal lobes are involved in impulse control and in planning ahead and in carrying through a series of tasks in multitasking. So we call it the executive function domain. And think of an executive of a company. He's got to be able to switch from one role to another very quick, from one set of rules to another. And when there's action taken, it'll be carried out through a series of steps. And so this executive function is a real problem for Parkinson's disease. So, what to do about apathy? It requires really external structuring of a plan for the patient. It can be planning 3 days a week of going out of the home for physical therapy, planning to come to Parkinson Place with a group dance therapy. Those are ways that you overcome apathy. And you can't really expect the person to initiate it. They may want to do it, but then when it comes down to it, they need a little bit of structure, they need to have a little bit or a lot of encouragement. And once they're here, and I'm giving this as an example, this is a wonderful environment to bring people who have some elements of apathy and Parkinson's disease. Of course, this Parkinson Place is much more useful for more than just apathy, obviously. It's useful in many ways, including utility for the caregiver. I'm going to switch now. Now, the anxiety and depression, those you can treat with medications. But apathy, there's no medication for apathy. It has to be environmental, it has to be structural, or scheduling, etc. And that's where the caregivers really play an important role. Now, I'm going to talk now about the compulsive behaviors of gambling, hypersexuality. Also, the part I didn't mention about dopamine dysregulation syndrome, which is what we're talking about now, is the tendency to overuse the dopaminergic drug and become addicted on the dopaminergic drug, where people take it beyond the number of doses that are used to alleviate the motor function. They take it because they feel better. It gives them a feeling of well-being. And much lower doses would allow them to move and walk normally, but they tend to use more and more. Their excuse to me and to their physicians is, well, they don't want to wear off. And they feel really, really good, and their mind is good, and they want to perform all these activities. So they tend to overdose, over-medicate, and end up taking much too much medication. And that creates a lot of this problem as well. So, what is this syndrome due to? Remember, you don't see it in Parkinson's disease without medication. You see it in patients with Parkinson's disease who are given dopamine replacement therapy. So what it is a dysfunction or abnormal function of the reward system in our brain, which many of you have heard me say is also utilizes dopamine. There are two major dopamine systems in the brain. What we call the nigrostriatal system, which we all know about. Any interference of function there results in Parkinson's syndrome, slowness of movement, rigidity, tremor, loss of balance. That's the dopamine nigrostriatal system, and if you replace dopamine, it replenishes that, and you can move better, walk better, etc. But there's another dopamine system called the mesolimbic dopamine system, known as the reward system. Anything that brings you pleasure releases small amounts of dopamine in what we call the limbic brain, which is the emotional part of the brain. And whereas the nigrostriatal system originates on the two little parts of the midbrain. Remember, everything is bilaterally symmetrical, and the midbrain, substantia nigra, the nigrostriatal system begins on the right and left. Nigra projects the right and left striatum. The mesolimbic or reward dopamine system is right in the middle of those two. And it's a different population of neurons, and they don't project to the striatum. They do project to what we call the nucleus accumbens, which is the emotional part of the striatum, which is just ventral or underneath the motor striatum. And then it projects further to the frontal lobes and to the limbic brain. So when you have a problem of Parkinson's disease, the first thing you lose, of course, is the nigrostriatal system. But eventually, if you lose the mesolimbic dopamine system, you may have periods of not getting pleasure out of anything. And when it's really severe, you have no pleasure at all. The anhedonia and the apathy. And so, because those projections of the frontal lobe are being cut out, so to speak, by the lack of dopamine neurons. So the dopamine neurons have different little clusters. The ones for the motor systems go first, and then the emotional ones go less. And even in a drug-induced Parkinsonism, like with this toxicant that destroys dopamine neurons, at a lower dose of this MPTP that kills dopamine neurons, you get a Parkinson syndrome in an animal. And much higher doses will also destroy the dopamine system of the reward system. So I'm giving you this as a background so you'll understand a bit more of why dopamine replacement causes hyperactivity of the reward system. And there's something about reward that's quite fascinating. It has a lot to do with anticipation of the reward. The pleasure comes not in the receipt of the reward, but somehow about the anticipation. So you can, one that's the most fun things I remember as a teenager was anticipating a date with a girl that I was crazy about. It was all this anticipation, and then finally going on the date was such a wonderful, rewarding experience. And it's the same with any anticipation. And imagine in gambling, there's a lot of anticipation. You're waiting for that payload, but you can't, and you don't get it, so you keep at it because you still have the expectation of reward. And so people can get into excessive, repetitive activities with the expectation of reward. That's a dopamine dysregulation syndrome. So the other thing I should point out before I talk more about the excessive gambling, hypersexuality, and obsessive compulsive disorders is that the drugs that block dopamine receptors are not selective. They block both the mesolimbic reward system and the motor system. So the first major tranquilizers that were developed in the 50s, the first one was Thorazine and then Haldol. Well, they treated people with schizophrenia or aggressive behaviors by preventing their emotions from acting out. So they blocked the dopamine system and the motor system. They were very non-selective. So as a result, they were aiming really to stop the crazy thoughts and paranoia, very active thinking that these schizophrenics had, this thought disorder, and they found that Thorazine would prevent that beautifully. The people became calm. They no longer had aggressive outbursts. But what they ended up developing is a Parkinson's syndrome, because that tranquilizer that stopped all their crazy thoughts also stopped their movements because it blocked the nigrostriatal dopamine system. So those early tranquilizers were not selective. They produced Parkinsonism as well. And that's what led to the insight that there was a dopamine issue in Parkinson's syndrome. And that led them to the discovery that there's not enough dopamine being made in Parkinson's disease, which led to the major treatment we use now, which is dopamine replacement, initially with levodopa or with synthetic dopamine that acts directly on dopamine receptors. So that's the background of mesolimbic versus nigrostriatal dopamine system. So when you, this dopamine dysregulation syndrome doesn't begin immediately that you begin treatment with levodopa or with dopamine agonists. Usually it takes time. It has to be given for many years, sometimes 5 years, a few years. And it really is characterized by problems of self-control that, like, you become very addicted to the medication itself. You develop gambling problems. You develop unusual sexual behaviors or hypersexuality. That sometimes is a complaint that a patient's wife will make to me. She said, I don't know, he never was that interested in sex before, but ever since he's been put on this dopamine drug, he just won't leave me alone. He can't get his hands off of me. I'm driving and he's pawing me. This is, what can you do about it? Well, if you take away his levodopa a bit, that would help, but then he can't move. So that's why levodopa and dopamine agonists got the reputation as being aphrodisiacs. Because when they first began to treat these people in wheelchairs that hadn't moved for years, and they got the first onset of the ability to move, they also got all kinds of stimulation of their pleasure system, and they were chasing the nurses down the hallways. Now, and so the reputation was, oh, this is an aphrodisiac. In fact, there's a bunch of interesting anecdotes I'm going to tell you about that. So how often is the dopamine dysregulation syndrome? I said it's not that common, really. It's about 4% of patients with Parkinson's disease have run into this problem. And they run into the problem after they've been on dopamine replacement drugs, most often the synthetic dopamines, in other words, dopamine agonists, not so much the levodopa-carbidopa. It's more likely with pramipexole or Mirapex, with ropinirole or Requip, with bromocriptine or Parlodel, in the old days with Pergolide or Permax. Those are all dopamine-like drugs that we use to complement, to supplement levodopa. And those drugs are more likely to, especially if you had a younger onset, to produce this syndrome. Let me try again, yeah. It's really, as I said, much more common in people with young onset Parkinson's disease. So here's an anecdote. I had a patient who was 36 years old. He was a lawyer and an amateur photographer. I saw him at the University of Miami, and he had stage 1 Parkinson's disease. And as typical for treatment for Parkinson's disease patients who have less than 60 years of age, we don't go immediately into levodopa. We started using Pergolide, a synthetic dopamine, in other words, a dopamine agonist. He did really well for many years, but I remember he was about 42 years of age when his wife began to say, you know, he has some, spoke to me privately, arranged to meet with me to speak about the problems he's having. He's having all kinds of sexual weirdness, and his behavior has resulted in the loss of 2 different housekeepers. And what his behavior was obviously he was chasing the women, but he wasn't chasing them he would put on unusual garments like his wife's underpants and tights, and then make advances to the housemaid. Clearly that was a real issue. So I reduced his medication. I thought of putting him on, and I did in fact, on a novel tranquilizer that would block that drive, that sexual drive that was perverse, you know, because the hypersexuality isn't just wanting to have more sex, it's wanting to have weird sex. This is most of the stories I get. Another thing that happened with him, he was probably the worst example of this dopamine dysregulation syndrome, and it's a classical thing, was that he became very hypervigilant at night. He was sure that his wife was always turning him down about sex, because he always wanted to have sex every day, including, she was a horseman, they have horses, she was a dressage. He would make her get on the saddle they had in their bedroom, you know. So anyway, strange things, but I figured you want to get some interesting anecdotes. And the other thing that was really got him in trouble and ended up with a call in the middle of the night from the police to me was that he was convinced that his wife was having an affair with a mafioso who lived next door. Now, there's no evidence the man was a mafioso. He had an Italian surname. They lived in a very beautiful part of Coconut Grove, and across the wall there was a beautiful mansion with an older, retired builder with an Italian name. And he was sure she was sneaking out at night and having an affair with him. He could tell because of his ogling of his wife. So one night in the evening, of course, so he'd never sleep. He was always making sure she was in bed, and he'd patrol the house and check the windows. He was worried that she'd sneak out in a way that he couldn't tell. And she went out he had run out of medications, one of his sleeping meds. So she went to the pharmacy to get it. It was around 9 in the evening, or 8, and he noticed she was taking a long time. So he started pacing and getting really upset. Then he went out to the driveway and thought he saw his wife's car pull up and not enter into the home. and she thought she was with this man. So he went into the house and got a pistol, went out into the driveway and fired the gun over the car. The car sped off. About 3 minutes later, his wife comes in. She didn't know anything about that. Right? And 5 minutes later, the police come. Because the man who was shot at called the police. There's someone firing a gun. And she was shocked. Police called me. They told me they were going to arrest him for firing a firearm. And I told them that, yes, he has a delusional and psychotic reaction to the medicines. I will take care of it. We'll give him the medication. There's no sense arresting him. And they were very nice. They didn't arrest him. So then I had to force him to take the novel neuroleptic drug, and made everything better. But after a while, he stopped taking that. He's no longer with us. He passed away about 5 years ago. But he.
The Italian guy shot him.
What?
The Italian guy shot him.
No, they actually moved to West Chase. What is it? Where did they have all? Because she was very much into horses. They moved to a place there's a lot of horses. No, it's west of Palm Beach. It's an area where, anyway, in West Palm. That wasn't Hialeah. So that's the worst case that I personally know of. I've gotten a lot. More common is we went to Las Vegas and my husband, I couldn't get him away from the slot machines, that kind of thing. And what I would do is take away the dopamine agonist and use more of the levodopa instead. So the dopamine agonists are more likely to result in that behavior. So what are some of the symptoms of the dopamine dysregulation syndrome? Number one is a craving for dopamine drugs. It's like, by craving means you really are thinking about it and waiting for it, and you feel very anxious until you get the next dose. And so you take extra doses. And it's very much like drug-seeking behavior for an amphetamine or cocaine. And typically they're younger people that do this. And there was actually a question as to whether, is this truly seeking the rewarding effect, the chemical stimulation like amphetamine or cocaine would do, which, by the way, as you should understand by now, releases dopamine into the limbic brain. That's how cocaine and amphetamines work. They potentiate the mesolimbic dopamine system, and needless to say, since they're not very selective, they also potentiate motor activity. So people who take cocaine and amphetamine are hyperactive, and they pace, and they're physically constantly in motion, and they have all kinds of involuntary movements and picking at their face and scratching, and develop stereotypic behaviors and obsessive compulsive. This is a normal person taking amphetamine or cocaine. They develop punding, which is do repetitive stereotypical things with no purpose. They will get into, if it's a woman who's doing this, she'll do house cleaning for 12 straight hours or spend forever polishing every bit of metal in the house. They get into this compulsive, repetitive behaviors. The stereotypic behaviors can be very weird too. I'm describing this because it's very similar to what happens with the dopamine dysregulation syndrome. It can happen in normal people who take psychomotor stimulants. But in Parkinson's disease, taking dopamine agonists can produce a similar kind of thing, which is an obsessive compulsive activity. But the what we call stereotypic kind of activities that can occur are taking apart like a watch, intricate devices, but then not putting them together again, that kind of thing. So increased craving, the other part about the increased craving, and it's a tremendous impulse to seek the drug and always kind of tell the physician, when I'm wearing off now faster, I need more. So they make sure that I give them plenty of drug. Now I'm wearing off every 2 to 3 hours, and many people do. But then to give them more of the quick-acting dopaminergic drugs is a mistake. Luckily now that we have a long-acting dopamine agonist, which are less liable to produce these impulsive behaviors, like Nupro, it just acts steadily, 1 patch per day. So that's one of the ways I would treat this disorder, is not to use a regular dopamine agonist. The case that I wanted to describe and I wrote a letter to the Movement Disorder Journal about it, is this. There was a case of a young man who had young onset Parkinson's disease, and he was taking pretty high doses of the dopamine agonist and had a diving accident in the pool. His motor control was well, and no one complained about it. I think he did take a lot of medication, but he felt he needed it to prevent wearing off. And he had mild dyskinesias, but they weren't excessive. So he was in a diving, this is a European case, actually it was reported out of Israel. He dived into a pool and fractured his neck. It was quadriplegic, sadly. This was reported in the Movement Disorder Journal. So here's a Parkinson patient taking a ton of medicine, and he was completely flaccidly paralyzed. And when he was conscious and he was, in recovering and undergoing physical rehab, basically they would just move him past. He had absolutely no volitional movement. He couldn't move at all. Didn't have rigidity. Now spasticity takes weeks to develop. So the first thing he began to do is ask for his anti-Parkinson drugs. He says, you haven't given me anti-Parkinson drugs since I've been in the hospital, I need it. He says, well, it's for Parkinsonism. You don't have Parkinsonism anymore, you're paralyzed. You have no slowness, you can't move. He said, I insist on. And so they gave him dopamine agonist and he felt better, even though it wasn't doing anything for his motor system. So that was an example. They said, so this is evidence that he was dependent, psychologically dependent on the rewarding effect of the dopamine agonist. So that meant that people would use that drug in excess, not to relieve their Parkinsonism, is why we give it, to prevent them from getting Parkinson, but just because it makes them feel better. And so it's very common in younger onset Parkinson's disease to take a lot more of the drug than is really needed for their motor control. And so they end up becoming kind of abusing it a bit. We don't like to call it abusive. It's a medicine that's used for relief of Parkinson's disease. And I don't mind the fact that it also makes them feel better, as long as they don't do it in excess and lead to this dopamine dysregulation syndrome. I often ask people, how did you do when you first take levodopa? They say, oh, I felt good. I said, that's not what I want to hear. I want to see, could you move better? Do you have less rigidity? It's amazing how many people will say, yeah, I feel better. Yeah, overall, that's good. But what I want to know, the reason I'm giving you the medicine, is to make you move better, to make the muscle tone better. Let me go ahead. And so these people who get psychologically dependent on the drug will take more medicine than they truly need. When self-administration is not allowed, because then, as it's happened in a few cases where they overuse it, the spouse or caregiver is the one that gives them the medicine, and they get really upset with that. Because I know when I need the drug, you don't know, but the doctor said I should take it every 3 or 4 hours. You should take, so there's always this kind of discussion. So when self-administration is not allowed in these kinds of patients, aggressive outbursts or the use of strategies such as symptom simulation or bribery to access additional medications can also appear. Now it's never gone that far with my patients, because I say it's only 5% of people with Parkinson's disease start running into this problem. So in the letter I wrote about this young person who was psychologically dependent and wanted the drug only to feel better, not because it was going to make him move better, I said, yes, it makes perfect sense, because all of the drugs that are abused by man and monkeys stimulate the dopamine receptors in the mesolimbic brain. And that there is an intrinsic reward capacity of dopamine agonists. In fact, dopamine agonists would be self-administered by an animal that doesn't have Parkinson's disease. I should give you a disclosure. I did my PhD in neuropharmacology at the University of Chicago, finished in 1976. What I worked on was the reward system for drugs of abuse in the rhesus monkey. So we set monkeys up to self-administer intravenously unknown drugs that the drug companies had contracted my boss to test to see if they had abuse liability. For example, a new weight loss drug. Company is required by the FDA to assess whether it's going to be an addictive drug or an abused drug. So I was very much involved in study of the mesolimbic dopamine system because cocaine, amphetamines, weight loss drugs all stimulate the mesolimbic dopamine system and make people feel good. You know, you feel well-being. Whenever you have a feeling of well-being or a feeling of, wow, that was pleasurable, that dopamine system is tickled, is being activated. So in the letter that I wrote, I said, well, all drugs of abuse by man have one component of action that is to stimulate the mesolimbic dopamine system. So of course it makes perfect sense. And this person who no longer has an nigrostriatal system, has any ability to use his skeletal muscles, he still needs his mesolimbic dopamine system. He's now dependent on having X amount of that drug there. Otherwise, he feels miserable. He was miserable, not only because of the accident where he was paralyzed, he just felt horrible because he was in withdrawal. He no longer had his dopamine action. So they restarted the dopaminergic agonist and things were much better. Let's see, okay. Other symptoms of the dopamine dysregulation syndrome that we see in Parkinson patients. Small number, but it's hypomania, kind of a little bit of it's not quite completely manic where you just are exuberant and want to do a million things and go out shopping and buy a whole bunch of stuff. That's mania, but just a little bit of high energy, hyperkinetic kind of thing. Feelings of euphoria, omnipotence, grandiosity. Sounds like Trump, doesn't it? But is part of the dopamine dysregulation syndrome where you feel, you know, grand euphoria, omnipotent and grandiose. But sometimes the dopamine dysregulation syndrome has just the opposite effect, where, especially during withdrawal, I should say, during withdrawal from the dopaminergic drug, that feeling of mania, hypomania, grandiosity, and well-being is reversed. And what is the reverse of that? Just feel dysphoria is the word, the opposite of euphoria. Euphoria is well-being, dysphoria is feeling of unpleasant being, you know. And how's dysphoria manifested? Well, fatigue, apathy, sadness, psychomotor slowing, so your thoughts get slower. So that happens when you withdraw dopamine agonists quickly, and especially it'll happen when you're using it in excess. So whenever we're going to decrease the anti-Parkinson drugs, you don't just go cold turkey. You do it gradually, otherwise you can get worse into dysphoria. The other aspect of the dopamine dysregulation syndrome is the impulse control. Like my patient from Coconut Grove, he had hypersexual drives and do weird things. He couldn't resist shooting at this guy. You know, he didn't know who would do shooting. I mean, that's an impulse control. Most people would have waited and see what was going to happen. Is she getting out of the car and then talk to her verbally, not go in and rush and get a gun and try to scare the mafioso. It's crazy. Compulsive shopping is one of the impulse control things. Gambling, eating disorders. People just begin to eat a lot of food over. I don't see that much in the Parkinson patients. But there can be behavioral disturbances with this dopamine dysregulation syndrome. People can develop psychosis, delusions, paranoia, aggressive tendencies. And that's what this case illustrated for us. How do we prevent the dopamine dysregulation syndrome? Even though it's a rare disorder, I'm always keeping an eye on it because it usually creates big problems for the patient and the family. Use the lowest dose of the dopamine replacement therapy. Just use enough that their motor function is normalized. Don't go over that. So if you notice, my patients always start with a very low dose and they build up very gradually to a dose that finally relieves their symptoms of slowness and rigidity. If you just give them a standard dose, that may be too high, and you're creating problems down the road. So the titration at initiation of these drugs has got to be slow, go low and slow. Minimize the use of the dopamine agonists that are of short duration. So that's why the companies are coming up with longer duration dopamine agonists, because they're less likely to produce this compulsive behavior. So like, for example, Mirapex or pramipexole usually has a short half-life of 3 hours or 4. Now there's a Mirapex extended release. It lasts longer, so you can get by with 2 or 3 tablets a day instead of 1 tablet 5 times a day or 4 times a day. The Requip is an extended release as well. And my favorite extended release, I say favorite because it's the easiest to use, and it's a 1-a-day patch, the Nupro patch, are the things that I would rather use and tend to use. And management requires enforcement of the dopamine drug dosage reduction. So if you have someone with this problem, before you start giving them the novel tranquilizers, which could end it, first try a very systematic reduction, just very slowly. You don't want to reduce it so much that they can't move as well, but enough that they start getting this, reduce their hypomania and their compulsive behaviors. And sometimes you just have to stop the dopamine agonist and stop the dopamine agonist for a while. Now, their Parkinsonism may be worse, but you can kind of compensate by having a little bit more of levodopa. And finally, the thing that I would do much more quicker now is use and this is the way I'd handle it, is use the novel tranquilizer drugs like quetiapine or Seroquel to control the psychosis, gambling, aggression, and hypersexuality. So it's very useful for all of that. And so I don't really see this as much of a problem. So I'm going to end here and take a few questions. What I feel is, what I covered is depression, anxiety, and apathy, with apathy being very difficult to discern from the typical motor problem in Parkinson's disease because of the mask, but also has overlap with executive dysfunction, with cognitive decline, and overlaps with depression. So it's a difficult thing to treat. What we do treat is the depression and the motor symptoms, and sometimes that results in less apathy. Depends on how much cognitive decline there is. Again, the apathy is then best treated with scheduling of activities for the person, to get them out of the house, to have things to do that are planned through the day, so they don't just sit in the, in their easy chair all day watching television or not even that. The second thing I talked about was this less common, but it's kind of a popular theme because when you hear about it, it's very striking, is the dopamine dysregulation syndrome. And that is compulsive gambling, hypersexuality, addiction to the dopamine agonists. And I'll end it there. There's a question that was already asked. Can Parkinson's disease affect breathing and lung function? Well, it doesn't affect lung function, but it affects breathing. And what is breathing? Well, when you inhale, it's a motor thing, right? Diaphragm pulls down, brings the chest wall, opens up. That's one cycle of breathing. If you have Parkinson's disease, the muscle rigidity is not just in the arms and legs and in the face. It's in your diaphragm, in your chest wall. So untreated Parkinson's disease, undertreated Parkinson's disease, never quite get deep breaths. And so you hear it in their speak, hardly any air is coming out. You have to learn to take deep breaths. And it works best if your motor function is improved with levodopa or the agonist. So yes, of course, breathing is affected by Parkinson's disease and is made better by dopamine treatment. But there's another kind of breathing problem. What is that? It's respiratory dyskinesia. You know what dyskinesias are. They're caused by dopaminergic drugs, especially if you use them at too high and younger onset patients. Anyone less than 60 who's treated with levodopa at high doses will develop dyskinesias, which are abnormal involuntary movements that are different than the tremor and rigidity. There's twisting, dancing movement like this. And there could be irregular breathing that's very frightening and you can't get air, so the breathing's fast. And then you end up going to the ER because you're sure you're having a heart attack, and that leads to a panic attack, right? I can't breathe. And you know it's a respiratory dyskinesia because it's your very irregular breathing, and it occurs an hour after taking Cinnamon. And once that would be called a peak dose dyskinesia. And you occasionally will see people have a transient irregular breathing. Once they know that it's due to the medication, they can take less levodopa if it's a peak dose phenomenon. There's an end of dose dyskinesia that occurs as the drug is wearing off, just before the next dose when that dyskinesia occurs. And then if it's involving muscles of the diaphragm and chest wall, you'll see it in the irregular breathing just before the next dose. They take their medication, if the medicine works, the respiratory dyskinesia, as other dyskinesias disappear. Important point to note, why is it that some people have respiratory dyskinesia and others don't? And one thing to recall is that the dyskinesias affect different parts of the body depending on where the striatum began to degenerate first. In many people it starts off as a limb on one side, and then eventually both arms. But in some people it all starts in the face. They start doing this and just head. Some people it's the foot starts dancing around. And then some people it's generalized dyskinesia. And some people it's the diaphragm. So any skeletal muscle can develop dyskinesia after taking levodopa for any length of time. So that was the answer, probably. Now, what about the lung? There's only one situation where lung problems, and it was called pulmonary fibrosis, where you have fibrotic changes in the lung. That happened with ergot-derived dopamine agonists. There are two. One is pergolide, and there was another one that, anyway, pergolide was withdrawn from the market because a very small percentage of patients would develop either pulmonary fibrosis or cardiac valve fibrosis. Extremely rare, but the company, Eli Lilly, withdrew the drug. It was a shame because it was a long-acting, very useful drug for dyskinesias, because it didn't produce dyskinesias as much as other agonists or as much as levodopa. But because of the effect on lung and heart, it's a weird idiosyncratic response. Just like a lot of ergot amines can do that as well. And I'll take a couple of questions. Yeah.
Where does Azilect fit in?
It fits into the pocketbook of the company that makes it. Let me give you some. What is Azilect? It's an MAO inhibitor. It's a drug that prolongs the activity of dopamine, because dopamine and levodopa are broken down by MAO and a couple of other enzymes. So by giving an MAO inhibitor, you get a little bit more action out of the dopamine. It lasts a little bit longer. There's another enzyme we use called COMT, or entacapone. COMT inhibitor also works in a similar way, but it's a different enzyme. It inhibits a different metabolic path for breakdown of dopamine. But the reason Azilect was pushed goes way back, and it goes back to about 85, when selegiline, which is the first selective MAO inhibitor, in other words, it's the first of the drugs to be used to try to slow down the breakdown of dopamine, was very, very popular because there was the concept that it may slow progression. The concept was, if you use less levodopa and less dopamine, you may slow progression of the disease, because as you metabolize dopamine and levodopa, you create oxidative stress. And MAOB would diminish oxidative stress. So there are two different actions of these drugs. One is to prolong the action of dopamine. The other is to decrease oxidative stress, which drives the degenerative process forward. I'm not finished. I'm telling what MAO is. Okay, and MAOB, the first one was selegiline. But then it was shown that it didn't slow progression of the disease, but we still use it. They made a cousin of selegiline, called it rasagiline. And they did a study that is, there's some evidence that it may delay onset of the disease in people. If you started, they have the first symptoms, maybe a little intermittent tremor, but they don't have full-blown Parkinson's disease yet. Or they have slowness and rigidity and tremor, but they don't need dopamine replacement yet. then you start them on Azilect, and that may delay the disease for a year, and then you would start off with the dopamine replacement. Now, Azilect, the problem I have with it is that a 1 milligram dose in the study seemed to be effective in delaying the need for levodopa, slowing progression, but 2 milligrams didn't. And so there's no dose response curve, which makes you suspect. And so what the company is suggesting is, even if it doesn't slow progression, it's very useful for smoothing out the response and wearing off. So a lot of people continue to use Azilect with levodopa, and they may end up using a little less levodopa. So that's Azilect, but it's very expensive. If people have problems with buying it, I just suggest selegiline instead, or Deprido. So there was a question that came up. What was your question?
It was along the same lines, but I think the idea, we didn't understand, you're talking about your natural dopamine, so it's trying to help control the
And also the
natural.
the dopamine made from levodopa is natural.
Mhm.
That's the beauty of the discovery of dopamine deficiency, because you're not making enough of it, is to give the system the natural precursor, which is this amino acid known as levodopa. It's found in all proteins. They just concentrate it into a capsule and add a little carbidopa so it's not broken down in your liver and gut. That's Cinnamon, because it's levodopa without nausea. No vomit, right? So it potentiates, so dopamine that you find in the brain is, it's all derived from levodopa. But in Parkinson's disease, it's mostly derived from levodopa. So what was the question? So the MAO inhibitor will prevent the breakdown of dopamine in general, and also
Whether you're on a prescription or not.
MAOB is active
Okay.
in breaking down dopamine and levodopa. It's how every neurotransmitter is synthesized, released, taken up, and broken down, right? If you prevent the breakdown, you get more action out of dopamine, so you get more duration of benefit.
Okay.
So the drugs I'm talking about inhibit the normal breakdown by MAO. That's why it's called an MAO inhibitor. What is MAO? Monoamine oxidase. It's an oxidative way of breaking down these neurotransmitters, and they don't only prevent the breakdown of dopamine, they prevent the breakdown of serotonin or adrenaline, because those are all monoamines. So when you take these kinds of drugs, you're increasing the levels of these monoamines, which are very critical neurotransmitters that are deficient in Parkinson's disease. And by this drug, you kind of can get by with a little bit longer, because you're potentiating, increasing the synaptic level of dopamine at the synapse. And that's it, because I got to get ready for the clinic. Thank you.
Thank you.